This conversation, which has begun, is a conversation that goes easily and without significant challenge. Actually, it's a lot of challenge to have this conversation.
And some of the frustration comes from how do we embed social science findings within a clinical environment?
I think it's long overdue. It's quite urgent that we do radically critique some of the taken for granted theories of change that have been in the field, some of them for some time. The debate we got into in our group was around the collaborative model. That's still extant, that's still being used, and it's still very, very difficult to tease out what is the underlying theory of change that drives that.
I think patient safety research and policy making has sought to create more knowledge, and I think what we are underestimating is the importance of creating safety through non-knowing, or the ability to be surprised, the ability to be attentive, and that comes from not assuming that you know the situation. And the other thing is that research and policy making has constantly anchored itself in objectivity, whereas I think the role of emotion is something that we have not really begun to engage with. It's something that can productively contribute to what we're talking about here.
I think the world economy is going to be telling healthcare that there has to be a massive reduction in costs. So I hope part of what we're thinking about is to say, how are we going to bring along issues of quality when the cost impact that we're going to have in healthcare in my country, and perhaps some of the other ones represented here, may be on the order of 25%. How will we do that?
We moved on to a discussion of, it was a little bit different, but kind of Kuhn's structure of scientific revolution, which has these three stages, I learned. Pre-paradigm, to normal science, and then to revolutionary science. And we had a rather lively discussion about sort of where does QI fit in that, and where does improvement interventions fit in that, this continuum of scientific revolution.
What I hear, and this is really my first immersion in this discipline, is a concept that is very difficult to penetrate the traditional biomedical model, is the notion of a treatment as a social change. When you bring that into traditional biomedical discussions, they don't, at some level, they don't understand what you're talking about, because we think of the treatment as the imaging, as the drug, as the device, as the actual intervention. And everything around that is simply sort of window dressing, context. And so I think that's what interferes with the understanding of what a safety and intervention is, because it doesn't have the same trappings as other biomedical interventions.
There's a sort of a feeling about, the pre-paradigmatic state as being a problem, and we should move as fast as possible to having a paradigm. And I feel very uncomfortable about that, and I would argue in praise of pluralism, which is what this conference is about, I think.
Sometimes I think about the patient safety movement and looking back and how it differs from quality, and why things that were known about for 50 years have, suddenly become a big priority. And a big key transition seems to me that whether it's road safety or patient safety or whatever, is that there's a point at which things become unacceptable. And what was tolerated suddenly becomes no longer tolerated in a sort of wide social sense. And it seems to me that us as citizens, if you like, if I go back to David's point about the apps, we want the demand for better healthcare to be more widely spread, and in fact the current situation to be less tolerated, which we would want in this room. But I think if we only work through the professional organizations, we'll never get there.
I think there's better need for a dialogue between the evidence-based medicine movement and the quality improvement movement, because the evidence-based medicine movement, I realise, has been mostly focused on the new technologies coming in, whether I should be doing them at all. Is this a worthwhile thing? Is it effective at all? What's the number needed to treat? Is this a great thing? And trying to get rid of things that are a waste of time as well, completely. Yeah. And it's just, but we only do a 50% job when they get in. Yeah. Okay, so we accept the right things, that's the sort of evidence process, but we then don't try and improve those, whereas you guys, the quality improvement movement's been focused on the things that have gotten in the door, but you're now trying to make them work properly. And I think you have to recognise the dynamic system and pay attention to them both.
Reflecting back on my early days as an HIV doc in San Francisco, frankly, the patients were in our face, and it was often quite uncomfortable, but it made HIV care much better. It made it, even at speaking as an academic, we were forced to organize our care in a way that took advantage of resources in the community and created or assisted in the creation of supports that weren't there.
Have you looked around and seen our colleagues? Not a Christine Keener among them, I'm afraid.
No, have not seen that. No, it hasn't.
No, I'm afraid they're all down the road, lounging about at the international colloquium of something even less useful.
There seems to me to be a question emerging about how we position the future development of improvement science, because we could position it as an evolution of where we are now, or we could position it as something radically different, a real revolution in the way that we're thinking. And there's some points that have come out, particularly in our group, I think, about the extent to which taking forward improvement science has to integrate the traditional disciplines of research and education and improvement activity. And the question is whether that integration produces something which is a compromise in each of those three disciplines, 3 areas of practice, or whether it's something that's very new and not a compromise.
We've got to change the unit of analysis, and I think you've inadvertently advised me about that. We've got to stop thinking hospital or structure or institution and start thinking system or community. The successful parts of the English health system are where people have lowered the boundary and started to span those boundaries, mobilise themselves socially to make things a little better. It's got a long way to go.
I wanted to echo Paul's thanks for both having this meeting and certainly for including me. I feel like many of the people out there who are not aware of the richness of this discipline and who we feel like we have to wake up. I was one of those. And going back to epistemology, I lived... You don't see the paradigm that you're in. It's like the water that the fish swim in or the air that you breathe. You can't see it. And I came to this meeting, and all of a sudden, I saw it. And before, I tended to think of QI, or whatever we're going to call it, as, sort of a lower-level intellectual activity to which maybe the best scientist wasn't worth spending their time. And now I take on the admonition of a statistician who once pulled me aside and said, don't worry about the little things, work on the big things. I now think this is one of the big things to which not only do I think it's worthy of my attention, I think I'd be very honored to think that I even was able to contribute a small part to its advancement. And it's so complex, it's far more complex, in fact, than many of the things they've ever given my attention to. So I want to thank you and everybody here for waking me up to that.